Um, yes, we are.
Lovely. Okay. Thank you. Well, welcome everyone. Thank you for attending tonight's webinar, especially on what's been such a lovely spring day today and such a beautiful spring evening. So we really appreciate you giving up your time to have a listen to the webinar this evening. The title of which is Are Statins Right for Me? And you've been invited tonight because either your hospital doctor has recommended that you take a statin and you're currently not taking one, or for one reason or another, you've had a cholesterol test. It may be that you simply requested one. It may be that you have either high blood pressure or diabetes, which are conditions that can all increase the risk of heart disease and stroke. And we checked your cholesterol as part of a risk assessment. Or it may be that you just saw a clinician who was doing some other blood tests and decided to throw in a cholesterol test. For those of you that don't know me, my name's Helen Rutherford. I'm afraid you can't see me at the moment. We've had a few technical hitches, so I'm a little bit worried if I uncloak and show you straight away that we will not be able to share the screens any longer. I'm Helen Rutherford. I'm one of the GP partners at Woking Medical Centre, and I'll be leading the first half of this webinar, followed by my colleague, Dr. Bardwaj. Now, both of us have a particular interest in what's sometimes called lifestyle medicine, and we will explain a little bit more about that later on. What we're going to do first, though, is we're going to get you warmed up with some questions. So the first question for you is, what is cholesterol? Have a little think about that whilst I explain a wee bit more about why we're here tonight. So the webinar tonight is based upon the face-to-face patient education sessions that we run in the practice at Woking Medical Centre, usually from around April to September each year. And we'd like this evening to be as interactive as our face-to-face sessions are. So if you have any questions, please put them in the chat. The webinar is also recorded, so you will be able to use this link to have another look if you're not sure about anything a bit later on. The reason we created the group education sessions is that as GPs, we see many patients who've had their cholesterol checked. The cholesterol result returns at a higher level than national guidelines would like. Or maybe the patient, you have what we call something called a Q-risk score. That's one of those questions up there, and something that we will explain a little bit later on. And your Q-risk score has returned at more than 10%, which means that guidelines advise that we should offer you a statin tablet. And when in the old way that we used to run things was that, you know, you'd have your cholesterol test, you'd have your Q-risk score checked, or we'd receive a letter from your consultant telling us they'd like to start you on a statin, and we would then get you in and see one of our clinicians for about a 10-minute appointment. This webinar is going to last about an hour, explaining the pros and cons, the advantages, the disadvantages of taking a statin is actually quite complex. And I think you'll see by the end of this that it's almost impossible for any clinician to achieve all of that in just 10 minutes of a one-to-one face-to-face. So we're hoping that by the end of tonight's webinar, you'll be you're better able to make an informed decision as to whether you wish to take a statin or not. So first question of the evening, you've had a little bit of a chance whilst I've been talking to think about it. Anyone brave enough to tell us what cholesterol is? Perhaps if you could put the answers in the chat. I've got Dr. Bardwaj monitoring that. I'm afraid I can't see it at the moment, but I'll give you a few minutes to maybe.
There's nothing so far.
Nothing so far. Okay, you're all quite shy. It'll take a little while to get warmed up. So let's move on. So cholesterol is a type of fat, the majority of which we manufacture ourselves. So only a small proportion of cholesterol is actually from our diet. And cholesterol is absolutely vital to life. Without cholesterol, we would die. So it's the building block for many hormones, many vital hormones, including one that you've probably all heard of, something called vitamin D, which is actually also a hormone. All our steroid hormones that we need in order to keep our bodies functioning properly, and all our hormones that are necessary for many body functions are all built around cholesterol. Cholesterol is also the building block for many of our sex hormones as well. So low levels of these hormones can cause lots of other symptoms, and in particular low levels of vitamin D can cause low mood or aches and pains in your body, and definitely sort of poorer brain function. So cholesterol is important. We always think of it as being something that's bad, but actually it really isn't. It's an important building block for many chemicals in the body. So I suppose the question is, why do doctors worry about cholesterol? Well, there's a hypothesis that a raised level, a high level of one of the fats in the body, the cholesterol called LDL, or the so-called bad cholesterol, is directly responsible for heart attacks and strokes. That's one theory. Statin tablets reduce the risk of patients who have already had a heart attack or a stroke from having another heart attack or a stroke. And they also lower this bad cholesterol level, this LDL cholesterol. So the conventional wisdom is that works because it lowers LDL cholesterol, and that's the reason why statins prevent heart attacks and strokes in certain groups of patients. I think the reality is likely a little bit more subtle, and it may be that patients, some of you of whom will be on this webinar tonight, who have already had a heart attack or a stroke or a mini stroke or angina perhaps, so patients who already have some furring up of their arteries and are building up something that we call a plaque, it may be that actually the statin acts as an anti-inflammatory in the blood vessels to what we call stabilize that plaque buildup, which is the stuff that can break off and then trigger blockages in blood vessels, small blood vessels, which then can trigger heart attacks and strokes. So the theory is that if we lower cholesterol by taking a statin, we'll lower the risk of heart attacks and strokes. But as I say, the reality is probably more complex. So some of you on the webinar tonight will already have had a heart attack or a stroke, or maybe been diagnosed with angina or something called peripheral vascular disease. And this means that you will have been advised to take a statin and many other medications, like say aspirin or perhaps something like a beta blocker, for what is called secondary prevention. This is the on the right hand side, the box on the right. And secondary prevention is when we try and prevent another heart attack or stroke or mini stroke, or prevent angina from developing into a heart attack. So many of you will also on this call will never have had a heart attack or a stroke. And the decision as to whether you should take a statin or not will be based upon a risk assessment, something that we call a Q risk. So if you look at the left-hand box there, that's what we call primary prevention, when you've never had a heart attack or a stroke and we're trying to prevent it. Okay, so the goal there is that we check many risk factors for heart disease or stroke, and we put them all into a special calculator called a Q risk calculator, and that again gives us an idea as to whether you are at higher risk of having heart disease or strokes, and that then determines whether we recommend that you take a statin tablet or not. But I think it's really important to remember that there are other things that may be at least as important, if not more important, than lowering cholesterol if you want to prevent heart attacks and strokes. And these may be changes that relate to our lifestyles. And that's where Dr. Bhardwaj and I come in, as we think that making lifestyle changes are really important in order to prevent heart attacks and strokes, and that it's never too late to make some changes. So we're not just going to talk to you about statins tonight, we're also going to talk to you about other positive changes you can make in your lifestyle that could help prevent future illness. So I suppose what is the most important thing when it comes to reducing our risk of heart disease or stroke? Raised cholesterol is one of a number of risk factors for heart disease, which also include things like this. So holding fat around your belly, being diabetic, pre-diabetic, having something called chronic kidney disease or CKD, having high blood pressure, All of these things on here, including the blood fats, are part of something that we call metabolic syndrome. And this group of conditions, they are related to each other. So it's completely reasonable to conclude that a sensible approach is that there's likely to be no underlying, that there's likely to be an underlying single cause, not 6 different causes. And we think that that underlying cause is this thing that we now call metabolic syndrome. There are other things that can increase your risk for heart disease as well. Obviously, an obvious one is that if you've already had a heart attack or a stroke, then you are going to be more likely to have another one, basically. So many of the conditions that are associated with metabolic syndrome can be addressed through lifestyle changes, what we call here doing the basics. Now, myself and Dr. Bardwell are both long-standing members of the British Society of Lifestyle Medicine, and this slide is taken from their website. And they outline what they call the 6 pillars of lifestyle medicine. So we need to eat well, we need to sleep well. If any of you are having problems with your sleep, I would recommend the NHS Sleepio app. It's free to NHS patients. If you just go online and put in Sleepio, Sleep.io, one word, into Google, it'll take you to their website. You can join that for free, and it runs a program of about 6 to 8 weeks of trying to help maximize your sleep. We also need to get outside and do some exercise. Hopefully, at least sometimes in the UK, like today, that would mean catching some rays of sunshine as well. And that's also very good for our vitamin D levels. We need to make time for our friends and our family. Make sure we don't snort anything dodgy or smoke or drink too much. And we definitely need to manage our stress levels, especially with recent circumstances, and particularly with everything that's going on in the world at the moment. Many of us are feeling really quite stressed and overwhelmed by things. But if we get these basics right, then not only should we add years to life, but also life to those years. Not many people want to live longer if they're chronically unwell. So these basics are very important. So now we get on to how we decide, if you've never had a heart attack or a stroke, what your risk of having cardiovascular disease is. Cardiovascular disease means, as I think I've said before, a heart attack, angina, stroke, peripheral vascular disease. And a Q risk score estimates your 10-year risk of developing cardiovascular disease. And it's used to calculate the risk in adults up to the age of 84 years. So if you're on this webinar and you're over 85, you definitely will not have a Q risk score to be seen in your notes, okay? It's going to be high simply because of your age. So at that point, we just decide we don't calculate it. NHS England has now advised GPs that if a person's Q risk score is more than 5%, we should talk to you about taking a statin tablet. And that if it's above 10%, we should actively be encouraging you to take a statin tablet. But we don't think the choice is as simple as that. So a recent paper which was published in 2024 alludes to this, that there is some disquiet amongst doctors regarding blanket statin prescribing. And I think if you look at this, the statement at the end is very important. There needs to be shared decision making. But shared decision making means that you as patients are given all the information regarding both the benefits and the side effects of statins. And I think you'll see as we go through this slide deck that, as I mentioned before, it takes a lot longer than a standard GP 10-minute appointment to be able to go through all those benefits and risks. And that's the reason really why we've developed our evening group sessions and the webinars. Just moving on. So if you've been invited to this session, then either you already have pre-existing cardiovascular disease. That means you've had a heart attack, you've had angina, you've had a stroke, you've had a mini stroke, you've been to see a vascular surgeon, you've had various bits and pieces done to try and improve the blood flow to your legs. And you've been advised probably to take a statin, but you're not taking one. So if you're one of those people, ignore the next few slides because Q risk is not applicable to you. The advice is that you should take a statin because of your pre-existing disease, okay? Now, if you have never had a heart attack or a stroke or any of those other things I've mentioned, then you need to know what your Q risk score is. And your Q risk score will have been calculated by your clinician when your cholesterol result returned, and you should be able to view that on your NHS app. If you can't find your Q risk score, remember it's only going to be calculated if you have never had a cardiovascular event, then please, at the end of this e-consult tomorrow, if you submit an administrative e-consult, that's our online consultation form, and just ask our administration team to let you know what your Q risk is, because then you can come back to the webinar and have a look at the what we call patient decision aids that we're going to go through in a minute to decide whether you would like to take a statin or not based upon your Q risk. So this is a very detailed slide, but it's basically here to show you that a number of risk factors are basically plugged into the Q risk calculator to sort of help determine your risk in addition to your blood fat levels. So, you know, you can see that it's very relevant if you're a smoker, if you're diabetic, if you've been on blood pressure medications. And if you remember that slide I showed you before about metabolic syndrome, you'll see that the majority of risk factors are associated with metabolic syndrome. But there are some other ones as well, which are related to inflammation and blood vessels. So, for example, if you're a migraine sufferer, or if you've had an inflammatory arthritis, something like rheumatoid arthritis, or suffer from something else more sort of a slightly more rare, something called SLE or lupus, again, which causes inflammation, then these are other risk factors for heart disease or stroke. Another big risk factor is having had severe mental illness, especially if you've had to take antipsychotic medication. So all of these things are entered into the Q risk calculator along with your cholesterol level, and that then calculates your score. So remember again, what we're talking about now is only relevant to those of you who have never had a heart attack or stroke. So it's relevant to people who we're thinking about prescribing statins to for what we call primary prevention. And this institution that's mentioned down here at the bottom, NICE, N-I-C-E, the National Institute for Clinical Excellence, have produced these patient decision aids to help patients decide whether to take a statin or not, depending entirely upon their Q risk score. Again, what I've said before is that NHS England recent guidelines have been that we should advise patients with a Q risk score of greater than 10% that they ought to take a statin, and that we also ought to offer a statin to those who've got a Q risk score of more than 5%. So we're going to start by looking at the benefits of taking a statin if your Q risk score is 10% or more. And all the circles on this infographic here, they represent people. So here we've got 100 people. And if 100 people with a Q risk score of 10%, and what that means is how likely are you to develop heart disease, heart attacks, angina, or have a stroke over the next 10 years, okay? So if 100 people with a Q risk score of 10% take a statin every day for 10 years, then 90 people out of that 100 will not get heart disease, that's a heart attack or angina, or have a stroke. But these 90 people wouldn't have developed heart disease or have had a stroke even if they hadn't taken a statin, okay? 6 people will develop heart disease or a stroke, even though they take a statin. That leaves 4 people who would have prevented having heart disease or a stroke by taking the statin. So 100 people take a statin for 10 years in order to prevent 4 people from having heart disease or a stroke. 100 people, statin for 10 years prevents 4 people having heart disease or stroke. Just have a little think about that, and maybe have a think about what you make of that. Perhaps put what you make of that in the chat, and we can discuss that a little bit later. Now, despite NHS England telling us that we should discuss statins in those with a Q risk score of 5% or more, this patient decision aid actually doesn't have an infographic. for a Q risk score of 5%. So I think that's telling us something. The lowest Q risk score on the patient information infographics, the patient decision aids, the lowest score goes down to 8%. And if you have an 8% Q risk, then the figures that we've just discussed about here in the 10%, they alter basically to a benefit of about 3 people out of 100 not getting heart disease if they've taken a statin. Okay, so let's crank it up a little bit. Now let's put it up to if your Q risk score is 20%. So again, if 100 people who have a Q risk score of 20% take a statin every day for 10 years, then 80 will not develop heart disease or have a stroke. But those are people who wouldn't have developed heart disease or had a stroke, even if they hadn't taken a statin. 13 will develop heart disease or strokes despite taking the statin, which leaves 7 people who prevent themselves from developing heart disease or a stroke by taking the statin. So 100 people taking a statin for 10 years in order to prevent 7 people from developing heart disease or strokes. Again, just have a little think about that. And we're going to crank it up much more to a Q risk score of 30%. So if 100 people have a Q risk score of 30% and take a statin every day for 10 years, then 70 will not develop heart disease or have a stroke, but they wouldn't have become ill anyway, even if they hadn't taken the statin. 19 will go on to develop heart disease or have a stroke despite taking the statin, which leaves 11 people who will have prevented themselves from developing heart disease or stroke. So 100 people take statin for 10 years in order to prevent 11 out of that 100 developing heart disease or strokes. What do we make of that? Any comments? I'm going to move on and we'll ask in a minute about comments.
There are none so far.
So far, okay. So we've talked now about about the benefits according to NICE guidance. We're talking still about primary prevention. So again, this is looking in a slightly different way about a way of thinking about taking statin drugs, this time taken for 5 years for heart disease prevention in patients who've never had a heart attack or angina. So this is just heart disease we're talking about here. And unless you know the potential side effects of statins, you can't make an informed decision as to whether you're going to take a statin or not. So the slide that we've got here is from a website called the NNT, and I can't recommend that website highly enough. It's not just for statins, for any medication. Have a look at what the evidence actually is for taking a medication. Yeah, I think one of my phrases that I use quite a lot is educate rather than medicate. And I do worry that as doctors, we have a tendency to reach for the prescription pad when actually we probably need to talk more with our patients about the pros and cons of taking medication. And the NNT is a brilliant website to have a look at because it goes through so many different treatments for various different diseases and really gives you a lot of information as to whether you think making a personal decision for yourself, whether it's worth taking the medication. And it talks about numbers needed to treat, the benefits of the numbers of patients needed to treat in order to gain some benefit, and the numbers needed to treat where you may get some harm as well, or what they might sometimes call numbers needed to harm rather than numbers needed to treat. So this website uses evidence obtained from something called the Cochrane database. And Cochrane is really the gold standard for medical research. It looks at systematic reviews from across the world, and it gathers all the available evidence worldwide. And they have a slightly different way of looking at the pros and cons of taking a statin. The NICE Q-risk patient decision aid that we looked at just a few slides ago, that lumps heart disease and strokes together. The NNT website separates the risk into actual heart attacks and strokes and looks at a score if you've taken that statin for 5 years, not 10. So according to the NNT, if you take a statin for 5 years for heart disease prevention, where you have never had heart disease, so this is again primary prevention, then no one's life was saved. So statins did not save lives according to the NNT. 1 heart attack was prevented for every 104 patients taking a statin, and 1 stroke was prevented for every 154 patients taking a statin. But what about the potential downsides of taking statins daily for 5 years? Well, 1 in 50 patients develop diabetes. That's not something you're ever told, is it? But look, 1 in 10 developed muscle damage. And the NICE patient decision age that we looked at in the last slide, it states much lower rates of harm. So it states that 2 out of 100 people, develop muscle pain because of the statin, and 1 out of 100 people who took the statin developed diabetes. I'm not sure where they get those figures from, because NICE is very vague, and it basically says that the evidence is from many large studies. And we don't have the figures here, but many GPs, including ourselves, know that many patients get side effects, sometimes gut side effects, sometimes memory problems, sleep disturbance, when they're taking statins. I'm not sure that's all recorded, because we're not very good in primary care at recording all of this, or really, it's not included a lot in much of the evidence. And I think we know that many patients tell us that they're taking their statins, but the reality is that they actually aren't. It's quite common. You'll go on a home visit and you look in the patient's cupboard where they keep their drugs, and basically there's a stockpile of statins that haven't been taken. So we have to think, why might that be? And this is a very interesting article that was published in the American Journal of Cardiology. Things are a little bit different in America. They have different sort of insurance schemes. They don't have a national health service. But basically, it was looking at how likely are patients to be compliant, to actually keep on taking statins that have been prescribed for them by their usually hospital doctors. And the data is a few years old, but it shows in this column here, statin adherence, so that you can see that's the 1, 2, 3, 4, 5, 5th column along. It shows you, the number of patients who continue to take their statins when they've been prescribed. So it ranges from between 50 to around about 80% continue to take their statins, but that's an awful lot of people who don't continue to take statins. And if you look in the inclusion criteria column here, you can see why they were put on a statin. So in all of the studies, other than that fourth one down, Yang et al., they're put on the statin because they have existing heart disease or stroke. So these are patients who basically have been advised to take the statin, not because there's some theoretical risk or they've had a Q-risk score done, but because they've actually got furring up of their arteries, either in their hearts or their brains. And most people who've had a problem, they do continue to take a statin, between 60 to 80%, continue to take the medicine. But as you can see in one of these studies here in Foodie et al., even those who've been told they're at highest risk of having another heart attack, they've actually had a heart event, there are high levels of them not taking the statin, with about 50% stopping it. Yang et al. Is looking at a group of patients with diabetes and no other pre-existing cardiovascular disease. So this is more of a primary prevention treatment. And again, only 53% of them continue to take the statin. So I think what it might suggest is that there may be reasons why patients don't take their medication. It could be that they can't afford it in the States. Maybe that's one reason. But that's quite a lot. If you look at this, quite a consistent thing that people aren't very adherent to their statin medication. And I think it suggests that maybe there are other reasons why they don't take them. We're telling patients who've, in the Yang et al. Study, for example, telling patients there that they've not had a heart attack or a stroke, they're basically well, got no symptoms. We're telling them to medicate. And if someone in that position gets side effects, then they're quite likely to think, well, forget that, I'm not going to take those medications. So I think we have to think, that perhaps side effects are downplayed, particularly by the pharmaceutical industry, who of course want us to spend lots of money on statins. And I do think that side effects are experienced by a significant number of patients on statins. Many don't get any side effects at all, but a significant number of patients do get side effects. And it might be that that's one of the reasons why some of you who are on this webinar tonight, who've been advised by your hospital doctors to take the statin but aren't taking the statin, maybe that's one of the reasons why. There is that old joke about doctors, isn't there? They don't make you live longer, they just make you feel as though you're living longer. and that could be what's going on there. So we're moving on to those of you who have known heart disease. This is again the Cochrane database has looked at evidence for those with heart disease. So this is just heart disease rather than peripheral vascular disease or the other things that we've mentioned. But this is looking at secondary prevention. So patients who are given statins for 5 years where they have pre-existing cardiovascular disease. So that's, heart attacks or angina, or maybe they've had an angiogram which has shown some coronary artery disease and they've been advised to take a statin by their cardiologist. And the NNT in this case does demonstrate more benefits. So this is what we were talking about, how there may be something else going on, not just lowering cholesterol in the method by which statins work, and that may be that it's anti-inflammatory. So here, one life out of 83 patients is saved if you take a statin for 5 years or more when you've had a heart attack or angina or some other coronary artery disease diagnosis. And more importantly, 1 out of 39 patients find that a fatal heart attack is prevented. So I think you can see that there's definitely more evidence of a benefit in existing disease, and that benefit, I suspect, maybe because statins are anti-inflammatory, or maybe they stabilize that plaque we were talking about before, the bit that furs up the arteries, and it perhaps works that way rather than just lowering cholesterol. I know there are 1 or 2 of you here this evening who aren't taking statins, even though you have been advised to by your cardiologist. And it may be that having seen this, you may want to sort of have another think about things. It may be that actually you've had such significant side effects that that's the reason why you no longer want to take the statin, and that's a perfectly reasonable reason not to. And that's where what we will talk about a little bit later, making some lifestyle modifications, can actually help you, because you have to think that cholesterol and lowering cholesterol is just one of a number of risk factors for cardiovascular disease. And if you can't tolerate statins, there are other things that you can do to help yourself. Remember again, the QRIS calculation only applies to those of you with risk factors such as metabolic syndrome rather than actual disease. So if you have had a heart attack, a stroke, angina, peripheral vascular disease, then actually there's no point in having a QRIS score, and there will not be a QRIS score on your NHS app for you to look at. Okay. Some of you here tonight, I know, have followed in the past our diabetes reversal programme, what we call DRP. And at our session 3 DRP, we discussed blood fats. It may be that perhaps some of you missed session 3. We will be restarting our diabetes reversal programme in April. That runs for 3 months, between usually April to sort of end of June. And then we do some catch-up slots sort of a little bit later on in the summer. If you are diabetic and you haven't attended, I would really encourage you to attend. We've had some fantastic results. Patients have really improved their diabetic control and just generally feel better. Many of them have been able to demedicate, and again, that makes them feel better. Fewer side effects because they're not taking as many medications, and often if you're taking multiple medications, the whole lot together is a problem. And if you can just reduce a few, that can make you feel a lot better. So those of you who are still doing DRP, who are on this call and who have perhaps had your cholesterol checked whilst you're actively losing weight, remember that your blood fats will transiently, temporarily increase because you're mobilizing fat and it's going into the blood vessels. So we need to make certain that we don't make decisions about statins until we've rechecked your cholesterol and the other fat in the body called triglyceride at least 3 months after you've your weight has stabilized. That's hugely important. And we talk about that in DRP3, but definitely we know that most of our patients who follow DRP actually find that their blood fat levels dramatically fall. But you can't look at that, you can't analyze that until your weight is stabilized. Okay, so I am now going to hand over to Dr. Bardwaj, who is going to talk about how we really reduce cardiovascular disease risk. But if there are any questions in the chat, maybe we can answer them, or we'll perhaps just answer everything at the end.
Thank you. Yeah. So before I do carry on, there are a couple of comments, and Dr. Rutherford outlined that we've had one or two slight technical glitches. It's always the case, isn't it? And so the ability to respond in the chat in real time, we actually for some reason we don't have that. And so so what I'll do, please be rest assured that you're not being ignored. We'll deal with those at the end. I'll perhaps deal with one right now. Somebody has written that he or she has had one or two technical difficulties themselves and has been logged out. Where can that individual get more information? If that question was about, where to find this recording, well, that'll be on the Modality Partnership YouTube channel. And actually you'll be able to see some other similar work that we've done with other groups of patients. So this will be there on the Modality Partnership YouTube channel. So as Dr. Rutherford has teased, how do we really reduce the cardiovascular disease risk if we perhaps conclude that statins are not the magic bullet that they are perhaps sometimes portrayed as being. So if I could have the next slide, please. So this is a repeat of the slide that we've already seen. And this was actually the output from an amazing study that was done over a 10-year period, tracking women in the US who were referred to a cardiologist with symptoms suggestive of coronary artery disease, in other words, the furring up of the artery. So they may have had chest pain. They went along to see their American version of a GP, who then sent them off to see a cardiologist. The cardiologist did a special type of X-ray called an angiogram, and then they were then followed up for 10 years. And these are the principal risk factors that were demonstrated to be associated with those women dying of further complications of coronary artery disease. And the study followed about 1,000 women, so it was a decent sample. So I've just sort of set the scene there a little bit, just demonstrating that this is a very significant study, and really reinforcing the importance of this thing called the metabolic syndrome. And if we go to the next slide, what does that mean? What do we actually take from that? And before I sort of go onto that, what I think is worth knowing that although we are in a sense proposing something that isn't purely about statins, the content of this slide is not even remotely controversial. This is frankly and I'm old enough to have done O-levels, this is in O-level biology textbooks, GCSEs for the youngsters amongst you. So this is not even university level biochemistry. So what we see on the left-hand side, so we're going to start with the left-hand side. We're going to see that the diagram has got 3 lovely tablespoons of honey, hasn't it? Well, it's just there as an illustration, but you can see in the text underneath that a diet that is high in carbohydrates. What are carbohydrates? Well, you can see the list. Rice, bread, pasta, noodles, chapatis, cakes, biscuits, pastries, and actually even fruit. These are foods that are high in carbohydrate. Carbohydrates get broken down to glucose. When we're doing the sessions with our patients face-to-face, I'll usually refer to blocks of Lego. One block of Lego is one glucose molecule. Put 10,000 of those blocks of Lego together, in other words, 10,000 glucose molecules, and what you've got is you've got a carbohydrate, otherwise known as a starch. So you eat some carbohydrate, whatever it might be, whatever your particular choice is, then what will happen is that they will get broken down. The carbohydrate will get broken down, but those 10,000 blocks of Lego will be broken down into 10,000 individual blocks of Lego or 10,000 individual molecules of glucose. The blood system cannot tolerate such high levels of glucose. And so what happens is that a hormone called insulin has to be produced, and insulin's job is to push glucose into the cells. So in other words, it has to take it out of the bloodstream and push it into the cells. And what you can see in the middle of that sort of beige colored panel is that something perhaps rather surprising happens. That glucose in this slide referred to as sugar. Glucose and sugar are often terms that are used interchangeably. That glucose is then stored as fat. So carbohydrates are broken down in the diet into glucose. Glucose is then pushed into the cells, all cells, muscle cells, kidney cells, brain cells, all types of cells, and it is then stored as fat. And the higher the carbohydrate level, that means the higher the insulin level, and therefore the higher the level of fat storage. You can also see that that process does other things, and none of those things are good. So high levels of insulin are responsible for the retention of salt in the kidneys, and that raises blood pressure. And if you remember on the previous slide, that those are one of those things that are related to the development or the worsening of coronary artery disease. So with high levels of carbohydrate, high levels of glucose, high levels of insulin, we have high levels of salt retention in the kidneys. That pushes blood pressure up. We have fat being stored as a result of being converted into fat under the influence of insulin. And then you can see at the bottom there that we end up with bad things happening. CKD is a term, an abbreviation for chronic kidney disease, diabetes, and then CVD is coronary cardiovascular disease. So cardiovascular disease means the development of furring up of the arteries, potentially in the heart or in the brain. So that's the effect of diet. A diet that is high in carbohydrate will do all of those things. But on the right-hand side, we've got this very depressed-looking chap with his face in his hands. And that is the effect of other elements of our lifestyle. And so what you can see there is the effect that other bits of the 6 pillars of lifestyle medicine have on a different hormone, and that hormone is called cortisol. So if you're constantly stressed for whatever reason, doesn't matter what the reason is, it can be work-related stress, family, financial, the state of the planet, all sorts of things, that releases what are called stress hormones. Cortisol is one of them, adrenaline, noradrenaline are others. But the point about cortisol is that cortisol does something quite specific. It is responsible for increasing glucose levels. So in a sense, it's doing exactly the same thing as what is happening on the left side of this slide. And other things will do that as well, generally related to elements of poor lifestyle. Somebody who's not sleeping very well, possibly because they're stressed, maybe because they're in pain. There could be other factors. They're not getting enough exercise, and they're not getting out into green space, etc. So what we often say that this slide is almost a summary of modern life, where we've got many folks in the country who are eating a diet which unfortunately is high in carbohydrates. It may be all that they can afford, or it may be that they're doing it in the mistaken belief that it's actually a healthy diet. Added to that, we've got the other elements of sleep disturbance, not getting enough exercise, those sorts of things. And that feeds into the central panel none of which is good. If I could have the next slide, please. So what do we do with that information? Well, we can sort of break it down and see if we can work on some elements of that. So we've established from the 2 slides ago that carrying extra weight around our abdomens or waist to hip ratio, that is one of the most important factors. And so what we can see here, and as you can see, these are all referenced, so and they're so that you know that they're legit, as it were. So you can see what the sort of the optimal hip waist to hip ratio is. Unfortunately, it is the case that for women, it seems to be the case that having a slightly narrower waist than men is important. And that probably comes into factors such as menopause, during which time weight tends to accumulate as well. So these numbers are evidence-based, and they show you what the optimal, what the best waist to hip ratio is. If I could have the next slide, please. For those of you who are not diabetic, do not ever become a diabetic, because again, as you're now probably able to give this presentation almost like I can, because we're going over sort of reinforcing territory. It's incredibly important to try and deal with as many elements of the metabolic syndrome as possible, and one of them is this phenomenon of insulin resistance, and diabetes and pre-diabetes are manifestations of that. These are the units that we use to measure sort of the diabetes risk. We no longer really just measure glucose levels in the blood, because that tends to be just a very sort of simple snapshot, not that helpful. This test, called an HbA1c, is effectively looking backwards in time over 3 months. And so an HbA1c level is in effect giving a risk level, which is based on the preceding 3 months. So an HbA1c of 41 and below is perfectly normal. That's where we want everybody to be. 42 to 47, that's what we call pre-diabetes. 48 and over, that's diabetes. The higher it gets, the worse things are. Many clinicians don't really actually have any time for this arbitrary distinction between pre-diabetes and diabetes. If you're a pre-diabetic, unless you do something radical, the chances are you're going to become a diabetic. So the key thing is just never, really just never get into that situation. We do this program called the Diabetes Reversal Program, where we try and get people to literally reverse their diabetes with a significant degree of success. Next slide, please. So all of this is influenced and sort of motivated by focus on healthy lifestyles. And I'm going to just make a little aside here. This is often portrayed as preventive, and it has no benefit for treatment. That is incorrect. Dr. Rutherford and I have been doing this long enough now to know that framing healthcare like this from a lifestyle perspective, breaking it down into food, sleep, activity, relationships, substance abuse, and mental well-being is just as powerful, possibly more powerful, in fact, probably more powerful than medication. So it's a mistake to dismiss this sort of approach as prevention, and then if we fail on prevention, then medication is the only option in town. That's misguided. Next slide, please. And the next slide. So at the end of this session, which will be in about 10 minutes' time, you will now be better informed about cardiovascular disease risk and the role of statins than probably 90 to 95% of the medical world. Now, that's a bold statement, and I might get myself into trouble for saying that. But as you've now realized, it's not a quick thing just to go through, would you need a statin or not? And in a sense, one of the questions that's been raised is from somebody saying that my cholesterol is 5.3 and my Q risk 28%. I'm 77 years old and would expect to get a heart attack in the next 10 years. If I was 57, a level of 5.3 would be considered excellent, question mark. Maybe. The issue is that actually it's all about Q risk, and you've now sort of seen what the meaning of Q risk is. It doesn't actually just mean that you have a 10% risk of a heart attack in the next 10 years. It's a bit more subtle than that. And then, of course, the position about statins is that you're now hopefully much more able to see what the nuance is, the benefits and also the risks. So what we need from you is for you to tell us whether you now want a statin, okay? Because as I said, you've now had a fairly significant sort of dissertation, as it were, on the pros and cons of statins, the background to this, the role of lifestyles, and so what we will do is send you an SMS message from the practice over the course of the next few days, probably within the next week or so, and it'll be quite simple. It'll be, do you want to take a statin or not? And so please reply to the text message. We sometimes jokingly say, we know where you live, so you can't hide from us. So we do need to know. It's very important because it's one of the things that we need to respond to, and we have to sort of do this every year. So the SMS will ask you a very simple question: yes or no, statin to take or not. We'll then send a prescription for atorvastatin, which is the most recommended one, to your nominated pharmacy, and then you just go along and collect the prescription and commence thereafter. Next slide, please. What happens then is that most of the time you're committing to a lifelong course of treatment. You're taking the statins for as long as you're alive, generally speaking. It's then falls to us to organise follow-up, which is principally blood tests. Statins can have effect on the liver, and so we do tests initially shortly after commencing the medication, but then on a yearly basis, as you can see. If you decide, having listened and watched tonight, and again, this will be available for you to go over and consolidate, and if you decide that the answer is no, then that's absolutely fine. We have put in your notes that you've declined. It's informed consent, but that's not a one-way ticket. If 2 months later you decide that you've made a terrible mistake and you want to go on a statin instead, that's absolutely fine, and we can do that for you without any problem at all. Next slide, please. If you decide either way, all of our patients at the practice have access to a health and wellbeing app and health and wellbeing coaches, and so they are people who are trained. They're not doctors, but they're trained in behavioral motivation techniques, and also in sort of dietary manipulation. And so they are folks that can help you. We've also developed over the last few years an in-house health and wellbeing app. I always say apps are just tools. Many of them are very similar. They look a little different. The main thing that's different about our app is that the content has been produced by Dr. Rutherford and me, and we've uploaded it specifically. So it's a little bit more sort of personalized. And again, you can let us know if that's something that you wish to avail yourself of. Over the course of the last 3 years, 13,000 modality partnership patients have used the app and the coaches with fairly significant benefits to their health. Next slide, please, which I think is the final slide. Yep, there we go. So thank you for listening. We should probably stop sharing screens now, I guess. And then I'll perhaps see about tackling some of these questions.
Okay, I'm going to risk stop sharing my screen. When I did that earlier, I lost the link, so I'll try it and see.
Oh, in that case, maybe that's not to then. Okay.
But I can't see the questions. That's the only problem.
Don't worry, I'll deal with the questions. So a couple of questions. A cholesterol test in January. So this person had a cholesterol test in January, but there's no mention of triglycerides in the results. Is that correct, or do I need to request it specifically? Do you want to tackle that one?
Yeah. So unfortunately, our local lab will not always check triglycerides. When we do our diabetes reversal program sessions, we talk about triglyceride as being the positively evil cholesterol, because we actually think it's a greater risk factor for heart disease than the so-called bad cholesterol, LDL cholesterol. But it is tricky because the local labs will not always do that. Sometimes they actually only check the LDL cholesterol even, or what's called non-HDL cholesterol sometimes. So particularly if you have taken a statin in the past and it's been perceived as a monitoring blood test, then it may be that the blood test that has been checked is what's just called non-HDL, so you won't get a full lipid profile. We can sometimes try asking the lab to include triglycerides. They sometimes comply with our requests, sometimes they don't. I think there's a myth out there that we instruct the lab and they do as we say, but I'm afraid the hospitals are a law unto themselves and that they don't do what GPs tell them to do. So yeah, it would be better if we knew your triglyceride level, we could try. If you come and see somebody and ask for that, then we can try rechecking the blood test. Maybe next time you have a cholesterol check, just sort of mention, could we get triglyceride put on as well? But it's a lab issue. Anything to add?
No, I think that's pretty much what it is, isn't it? It's I would love to be as powerful as people sometimes think we GPs are, but sadly that's not the case. There's only one other question as far as I can see, and that's that some people have additional medical conditions as well as heart and stroke related conditions. Do you recommend an individual appointment with a doctor to discuss statins to ensure the right decision is made, taking all factors into account?
Yeah. So what I'd say to that is that the Q risk calculator actually takes into account the relevant medical conditions. There are two Q risk calculators. One calls Q risk 2 and the other is called Q risk 3. Q risk 3 actually includes more information about, say, inflammatory conditions such as rheumatoid arthritis or severe mental illness, and includes that in the risk. In my experience, it usually only increases the risk by around about 2%. The problem that we have in general practice is that our IT systems have not caught up. So the embedded Q risk calculator within the electronic medical record that we use is Q risk 2. So when you look on your NHS app, you may only see your Q risk 2 risk. You can actually just go online yourself and plug in the figures for Q risk 3, but in my experience, it usually only raises things by 2 or 3%. So if you know your Q risk 2 risk, then and basically add maybe another 2 to 3% on it, then that gives you more of a risk to then look at those patient decision aids. But the decision is really related to whether you think it's worth it, according to the Q risk score and the patient decision aid. So you're not going to get that much more, to be honest, in discussing it on a one-to-one, unless you've had many side effects from various different statins and you're thinking, well, actually I'd quite like to try a different type of cholesterol lowering drug, and that may be something that then it would be worth asking for an appointment to see one of the clinicians at the health centre, at the medical centre.
Yeah. And as I said, sort of generally now, with the information that you've hopefully absorbed over the last hour or so, you've got a decent feel for the level of risk and how it changes with a Q risk of 10%, 20%, 30%. There are no more questions, and we are at 7:30 p.m. So I think if there's nothing else, then what I'll do is I'll bring this to a close. No, I shouldn't bring this to a close. Dr. Rutherford, you're in charge.
I'm just amazed that we've run to time.
We've done an outstanding job. Well done.
Yeah.
Okay.
Thank you very much to everybody for joining, and remember that the webinar is recorded and is available to you in posterity, so you can look at it whenever you like. Just go back to it, and any queries, as I say, regarding your QRIS, then put in an administrative e-consult and we'll be able to hopefully answer those questions. Thank you. And also an administrative e-consult if you'd like a referral to one of our coaches. Great. So I'll just say thank you very much for listening, and we'll see you at the medical centre sometime. Good evening.
Sharifi, are we offline now?